Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, MARKUS HOMe welcomes Dr. Biff Palmer in El Paso, Texas, to discuss metabolic alkalosis. Dear Biff, we're blessed to host you for a second time this year. Thanks for taking the time.
Well, thank you very much, and I really appreciate the opportunity to visit with you and the listeners.
Dr. Biff Palmer is nephrologist and professor in the Departments of Internal Medicine and Medical Education at Texas Tech University Health Science Center in El Paso, Texas. His academic work focuses upon physiology and pathophysiology of human electrolyte regulation, and he has published numerous papers in leading nephrological and internal medicine journals. Together with Dr. Debbie Clegg, Dr. Palmer has now co-authored a treatment standard paper on metabolic alkalosis in NDT, which NDT's editor-in-chief, Dr. Anders, Andreas Kronbichler, and I selected as our NDT's pick of the month for a detailed discussion on MARKUS HOMe. So thanks again for being with us.
Well, thank you, Gunnar and Andreas. I really appreciate the opportunity to speak with you and the rest of the audience. And so, again, the title of the paper is Metabolic Alkalosis Treatment Standard. Before we get into the treatment, we spend a great deal of time in the paper discussing some pathophysiology, particularly because there's been some new insights into this metabolic disorder, and we felt that it was important for the readership to have a thorough understanding of the pathophysiology before even entertaining treatment. So let me begin by just saying that metabolic alkalosis requires both the generation of new bicarbonate and an increase in the capacity of the kidney to reclaim filtered bicarbonate load. This was really the emphasis by this famous paper by Dr. Selden and Floyd Rector in one of the earliest editions of Kidney International back in 1972. But the point that those investigators made was, if you give bicarbonate to an otherwise normal individuals, there's really only a minimal increase in the plasma bicarbonate because the kidney has an incredible capacity to rid that bicarbonate load. On the other hand, if you give a bicarbonate load to somebody who has a maintenance factor in place, the most common one of which is a low effective arterial blood volume, then the plasma bicarbonate concentration rises rapidly and is sustained. And so the whole concept that Selden and Rector made was that to have a meaningful metabolic alkalosis, you have to identify some process that generated new bicarbonate, but also have a process that's maintaining increased capacity of the kidney to reclaim the filtered bicarbonate load. This is just a figure from our paper. It illustrates the mechanisms of bicarbonate reabsorption in the proximal tubule. As the readership, I'm sure, is aware, this is a high-capacity system. Nearly 4,000 milliequivalents of bicarbonate is filtered and reabsorbed by the proximal tubule. In this segment of the figure below, you see what is also appreciated, and that is there is a tubular max for bicarbonate reabsorption. That is, when the plasma bicarbonate minimally exceeds the normal value, notice that you promptly excrete that bicarbonate load. So again, it goes back to the idea that just giving somebody bicarbonate, you can't really increase the plasma concentration because you simply overwhelm the reabsorptive capacity of the proximal tubule. That's one of the important points we make in the paper. One clinical example of this would be the alkaline tide. When we eat a meal, we secrete protons to process digestion, but for every proton secreted by parietal cells, a bicarbonate is released in the basolateral surface, and there's a transient rise in the blood pH. What has recently become discovered, though, is that there's also a major role by the distal nephron in bicarbonate secretion, again, through the beta intercalated cell, and specifically this protein called pendrin, which secretes bicarbonate in exchange for chloride. Recent data that we cite from Denmark, those investigators have also identified that part of the correction of that alkaline tide is not just the filtering of bicarbonate exceeding the capacity of the proximal tubule, but active secretion here in the distal nephron. What these investigators have found is that following a meal, the enteroencrophene cells, the S cells in the intestine, release secretin. Secretin then binds to receptors on the basolateral surface of the beta intercalated cell, stimulating then pendrin to cause bicarbonate secretion. So this is kind of an interesting physiologic concept. Furthermore, we now know that this beta intercalated cell actually has pH sensing capability. There's papers showing that this receptor, the insulin receptor related receptor, responds to changes in plasma pH, which in turn regulates the insertion or retrieval of pendrin from the apical membrane. In addition, this protein, the sodium-dependent chloride bicarbonate exchange, AE4, also plays a role. For example, when the blood bicarbonate concentration rises as bicarbonate enters into the cell, it again activates pendrin to cause more bicarbonate secretion. And so again, the complexity of this beta intercalated cell is really continues to increase. I also wanted to point out this pathway of alpha-ketoglutarate. It turns out that there's actually crosstalk between the proximal tubule and the distal nephron in the regulation of bicarbonate secretion. It's well known that a base load to a rodent model leads to an increase in the plasma concentrations of alpha-ketoglutarate and subsequent increases delivery of alpha-ketoglutarate to the distal nephron. This probably is thought to play a role in trying to minimize kidney stones. By that, I mean, with an alkaline load, as you excrete these organic anions, which is potential base, it allows for more base to be excreted without a major rise in the urinary pH, which could be advantageous to minimize nephrolithiasis risk. But what has been found is that as alpha-ketoglutarate is increased, it can bind to specific receptors on the beta intercalated cell that actually activates pendrin and promotes bicarbonate secretion. In other words, it minimizes the degree of metabolic alkalosis that would otherwise occur. The other thing to note is that with the stoichiometry here of pendrin and the apically located sodium-dependent chloride bicarbonate exchanger, you can actually get electroneutral sodium chloride reabsorption without K wasting. So in other words, you can cause salt retention without K excretion. Similarly, the alpha-ketoglutarate directly inhibits the ROM-K channel, which would also tend to minimize K secretion. So it's an interesting paracrine mechanism that exists within the kidney. So one of the things, and this is a statement from our paper, this prodigious capacity of the kidney to get rid of bicarbonate loads may be a teleologic vestige because our Paleolithic ancestors were thought to eat a diet that was much more alkaline in nature, and that diet had a lot of potassium. So as all of this bicarbonate would have been excreted, or potential bicarbonate, it turns out that increasing the urinary pH actually allosterically modifies the ROM-K channel to promote K secretion. So the alkaline diet, which contains a lot of potassium, all work together to promote the excretion of that high dietary K. Now, I wanted to also present a case to the audience. A 36-year-old man, he presents with generalized weakness, muscle cramping, lightheadedness. He works in a hot, humid climate and experiences excessive perspiration. And he goes to his doctor and he's found to have hypokalemic alkalosis. He's clearly alkalemic by blood pH, and you can see that he has a very low urinary sodium, a very high urinary K. His review of systems is only noteworthy for a history of infertility, which disclosed azospermia. So in other words, an otherwise normal person who develops hypokalemic alkalosis with a hot environment and has infertility. So I asked the audience, which of the following would you expect in this individual? A mutation in the beta subunit of the ENaC channel, bilateral absence of the vas deferens, suppressed plasma renin and aldo, low sweat chloride, or hypercalciuria? And so I just wanted, this is an illustration of a patient who actually has a very mild form of cystic fibrosis. Congenital absence of the vas deferens is found in a small percentage of people who have azoospermia. But notice 95% of men with cystic fibrosis have this defect, absence of the vas deferens. And this is related to this CFTR mutation. So here's the exocrine gland, specifically sweat glands. Notice that as sweat is initially formed, it's isoosmotic. But as the sweat moves down, the tubular cells reabsorb sodium and chloride, of which the chloride is going through the CFTR channel, promoting what is normally a very hypotonic fluid. But if you have a mutation in that CFTR, you can't absorb the sodium chloride and it becomes more hypertonic and you lose a lot of sweat chloride. This process is thought to occur during the embryologic development and accounts for inability to differentiate or promote the embryologic vas deferens. That's why you develop the azoospermia. The reason I go through that is we now know in that beta intercalated cell, there is the CFTR channel. And there are data to show that when this CFTR channel is no longer present, the activity of pendrin is removed, and you lose then this ability to secrete bicarbonate in the distal nephron. Indeed, cystic fibrosis patients have a much higher risk for developing metabolic alkalosis because presumably of this particular physiology. So the answer in this particular case would have been absence of the vas deferens. A second point or example of a case, which one of the following set of urine electrolytes would you find in a patient with active vomiting? And I give you these choices, and I just wanted to review briefly the physiology because we highlight this in the paper. Remember that in vomiting, this is an example of an extra kidney metabolic alkalosis. It's generated extrarenally. So with loss of gastric juice, you lose a tremendous amount of salt, promoting a reduction in effective volume. You also lose, obviously, hydrochloric acid, which is the equivalent of adding bicarbonate to the body. So with the active vomiting, the amount of bicarbonate that's being generated is readily filtered and exceeds the reabsorptive capacity of the proximal tubule, and you now have a very high distal delivery of sodium bicarbonate. Aldosterone levels are quite elevated in this setting due to the volume depletion, such that some of the sodium that's presented distally will be reabsorbed, increasing luminal electronegativity, promoting the loss of K. So the typical urine chemistries with active vomiting would be a high sodium, a high potassium, but notice that chloride is quite low simply because in response to volume contraction all along the nephron, sodium chloride will be retained. There's nothing dragging chloride out into the urine, and we'll also have this very alkaline urine pH. But as the vomiting ceases, and with no correction in place, in other words, the patient has hypokalemic alkalosis, his vomiting stopped about 12 hours ago, let's say, he is left with a low volume. The high bicarbonate that's being filtered now is completely reabsorbed because the maintenance factors are totally intact. Low effective volume, hypokalemia, promoting augmented reabsorption, in essence, increasing the tubular max of the proximal tubule. And in this setting, were you to check the urine chemistries, the sodium, potassium, and chloride would all be low. And notice that the urine pH would be much less alkaline. In fact, some people refer to this as a paradoxical aciduria, but it really represents the fact that you've come into this new equilibrium. So the correct answer in this individual would have been high sodium, low chloride with active vomiting. Once again, if the patient had more remote vomiting that was now in an equilibrium, both would be low. The first set of electrolytes might be somebody with diarrhea with a lot of ammonium chloride in the urine. So again, one of the figures in our paper is shown here where we talk about various causes of extrarenal metabolic alkalosis. Some of the lists here are shown. The other obvious big category for metabolic alkalosis is that which is generated within the kidney. And one of the things we point out is to understand how the kidney generates metabolic alkalosis, we have to be familiar with this reciprocal relationship between distal delivery and mineralocorticoids. By that, I mean with a low effective volume, somebody who goes, for example, out and exercises, we activate the renin-angiotensin system and aldo goes up, but we don't get K wasting or we don't get metabolic abnormalities because distal delivery is reduced due to augmented proximal reabsorption. Similarly, if we were to eat a high salt diet, we suppress aldo and we increase distal delivery. Once again, we don't get K wasting, we don't get metabolic abnormalities. There's always an inverse relationship between distal delivery of sodium and aldosterone. But when these two factors become connected, high aldosterone or aldo-like activity and high sodium delivery, this leads to K wasting, but it can also lead to a metabolic alkalosis. And if you have a patient in whom you think this connection has occurred, you have to then ask yourself, is the primary abnormality an increase in aldosterone, or is the primary abnormality an increase in distal sodium delivery, which is defined as a high sodium delivery not due to volume expansion? So when you have this connection, high sodium delivery and high mineralocorticoid activity, this is a figure from the paper. Again, you're going to augment sodium reabsorption. The lumen negativity will increase, and this is going to cause K wasting. But in addition, the increased luminal negativity will promote an increased rate of proton secretion from the alpha intercalated cell and cause generation at the level of the kidney of metabolic alkalosis. The hypokalemia that develops exacerbates this process because remember, hypokalemia in rodent models lowers the GFR and thereby lowers the filtered load of bicarbonate and also promotes increased proton secretion in the proximal tubule and increases ammoniogenesis, all of which would augment proximal acidification, contributing to the generation of a metabolic alkalosis. So when we think about renal generation of metabolic alkalosis, we divide those patients as to whether they have hypertension. So in anybody who presents with hypertension, hypokalemia, and metabolic alkalosis, we can understand the differential by measuring the renin and aldosterone levels, and we provide a list of the things to think about based on what those values end up being. In the otherwise normotensive patient, these are disorders where the primary defect is an increase in distal sodium delivery. We can divide according to the urine chloride. When it's low, we're talking about a non-reabsorbable anion effect, as with active vomiting or the administration of these antibiotics, or the increase in distal sodium delivery and chloride would be because of loop diuretics or their genetic equivalent, or even MAG deficiency. We then, in the paper, discuss the treatment. And again, the critical issue here is assessment of effective arterial blood volume. So when effective arterial volume is low and the urine chloride is low, these are going to be the classic saline responsive metabolic alkalosis. We're talking again about vomiting and NG suction, this congenital disorder, congenital chloriduria, post-hypercapnic alkalosis, diuretics, and the like. If you have a patient, though, who has volume contraction, but the chloride is low, or chloride here is high, once again, this becomes more of a saline-resistant type of metabolic alkalosis. Again, we're talking about active diuretic use, the genetic disorders, Bartter and Gittleman's, or MAG deficiency. And then lastly, the urine chloride could be high with an expanded volume. These are hypertensive disorders. Once again, sodium delivery and mineralocorticoid activity are both increased. And again, the therapy here is going to be directed against the underlying disorders. So for example, in Little syndrome, one would use an ENaC channel blocker. And in other things, you would try to correct primary hyperaldosterone. Again, we talk about briefly those types of therapies. So again, metabolic alkalosis, this is a disorder that's been reviewed many times over the last several years, but we think what's unique in our paper is we discuss some of the new pathophysiologic understanding of the disorder, particularly as it relates to the distal nephron and the role of bicarbonate secretion. And then we talk about the therapies for the various disorders. So again, I'd like to thank you very much for the opportunity to participate. Now, be happy to entertain any questions.
Thank you, Biff. That's excellent. And I was, for the first time, reading about the Bend-Red syndrome and was asking myself, how frequent is that? Do you have an estimate?
Yeah, so there are patients who have a congenital mutation in pendrin, and they have so-called pendrin syndrome. What's interesting about those patients is the way they present is with typically thyroid abnormalities, because this chloride bicarbonate exchange also works with iodine transport in the thyroid. So they classically present with thyroid disorder, and they have no renal phenotype at baseline. So they have no electrolyte disturbances. But what has been described is that the patients who have pendrin syndrome, should they, for example, be put on a thiazide diuretic, a process that's known to generate new bicarbonate, they get explosive metabolic alkalosis because the pendrin is no longer there to help correct the disorder once it would develop. Or if they develop a gastroenteritis with some vomiting, they get a much severe degree of metabolic alkalosis. So at baseline, they seem to be okay from an electrolyte standpoint, but they become at risk for much more severe alkalosis should some process that's generating it develop. But it's not common, and I don't have the exact frequency.
Yeah, it seems to be pretty rare. And then you discuss secretin deficiency or secretin, and I was just wondering if there has been basically kind of genetic disorder also linked to secretin deficiency. Are you aware of something like
that? I'm not aware of any specific disorder of inability to make secretin or, for example, a defect in the secretin receptor. But again, the work from Denmark clearly shows that secretin seems to be an important and unappreciated regulator of bicarbonate homeostasis. It is of interest that the patients with cystic fibrosis, who again have this impaired pendrin activity due to the absence of CFTR, that some of these individuals do have higher secretin levels in the blood, perhaps as a compensatory mechanism to enhance any residual bicarbonate secretion that may be there. What I found interesting is, again, there are these reports of patients in the literature who have a very mild form of cystic fibrosis, such that the only manifestation they had is just as I presented, where in a hot environment, they suddenly get these hypokalemic alkalosis, but otherwise they're doing fine. But the only other thing they have is this absence of the vas deferens. So we have to remember that cystic fibrosis is really a wide spectrum disease of very severe manifestations to these incredibly subtle presentations. But specifically, the answer to your question, I'm not aware of any defects in secretin per se. They may exist, but I don't know. The other thing we talk about in the paper too is, when people develop metabolic acidosis, it kind of creates an urgency and everybody gets excited about it. And sometimes you might take a lackadaisical approach to metabolic alkalosis, but in fact, alkalemia can be very dangerous. It's number one, suppresses respiration. Number two, it can create ischemic changes because alkalemia constricts both cerebral and coronary blood flow. And it also shifts the O2 dissociation curve to the left, perhaps impairing unloading of oxygen to the tissues. So while we may take a lackadaisical approach to alkalemic patients, I just think it's worthwhile for the clinician to think about some of the dangers of alkalemia.
I have two questions on diagnosis and then maybe two questions on treatment in addition. So for diagnosis, In your paper, you suggest us to measure the respiratory compensation and give a formula that states that an increase of bicarb by 1.0 would require an increase in CO2 of about 0.8. And if this is not within these ranges, then there's an additional problem when it comes to respiration. So should we apply this assessment in clinical practice?
Yeah, I think so. I think that's generally the relationship that's been described. So in other words, if somebody had a bicarbonate concentration that was assuming a value of 24 milliequivalents per liter and it was 34, if the body was compensating totally in an appropriate fashion, the PCO2 would, instead of being 40, would be 47. So 7.7 for every one. If in an individual, though, with a bicarb of, let's say, again, 34, if that PCO2 was now up by 14, again, that would be what I would argue a superimposed respiratory acidosis. In other words, something is suppressing the respiration beyond the pH effect. Or alternatively, if the PCO2 in that example was not 47, but was 42, then again, there would be something independently driving the respiration and it'd have respiratory alkalosis. So again, I think the relationship holds. That is, with a primary increase in bicarbonate, the PCO2 goes up by 0.7 for every one increase in the plasma bicarbonate.
And the question...
Mixed disturbances, as you well know, are quite common. Yeah.
The second question would be, so it's in clinical practice quite difficult for nephrologists to get urinalysis, measurements of electrolytes in urine. So are there patients in whom you would even recommend to do electrolyte measurements in gastrointestinal fluids, which surely would be even more difficult in clinical practice? So would this give additional information, or can we just estimate that people who are vomiting lose so many hydrogen ion that it's not worthwhile to do any further measurements here?
Yeah, I mean, for me personally, I can't think, I've never really routinely measured stool electrolytes, for example. I'm not sure how, obviously in somebody who had diarrhea and you're trying to differentiate a secretory from an osmotic diarrhea, there may be a role for urine chemistry, or excuse me, stool electrolyte measurements. But otherwise, no. The issue sometimes comes up, in people with ureteral gastrointestinal diversions. Can you still check urine chemistries when the urine has been exposed to the bowel? I think they become much more difficult to interpret in that setting because obviously the bowel has chloride bicarbonate exchange, a whole host of exchange mechanisms. So I think the only role for stool electrolytes would be in the differentiation from an osmotic versus a secretory diarrhea. But it's an interesting question, and I think kind of largely unexplored, really.
But it's good for us to know that even you do not do that regularly, so we are kind of relieved. And another question would be this idea of a generation phase and a maintenance phase is somewhat unique among all electrolyte disorders. So I do not know about any other electrolyte disorders in which this is in this two-phase model. So is this an academic approach which has been coined, say, 5 decades ago and now remains in the textbooks, or is this really so different from all other electrolyte disorders?
Yeah, I think it is somewhat unique with regards to this acid-base disturbance but I do think it is useful. It's almost intuitive that we do it that way. For example, when you think about somebody with a metabolic alkalosis, we always try to understand, okay, how did it come about? In essence, you're asking the question, how was it generated? And then that once you know how it's generated, you try to remove that generation phase. But alkalemia and the electrolyte disorder will be persistent until you've also then addressed what's maintaining it. And that's where the decision to give saline in chloride responsive metabolic alkalosis, or are you left with just trying to treat the underlying disorder? So I do think it has clinical relevance, that is always asking the question, okay, what generated, but also what's maintaining it? Again, think about, for example, somebody who had been abusing diuretics for some period of time, and then they stop it, 36 hours ago. If they have not yet received any form of therapy, they will still have a persistent hypokalemic alkalosis. The generation is no longer there. The drug is removed, but you then have to, replenish volume with a chloride-containing solution to remove that maintenance factor. So I think it has utility, but I agree with you. I can't think of, another acid-base disturbance that we look at in quite that same way. Yeah.
Which makes it even more difficult for us to understand this very complicated, actually, electrolyte disorder. And then maybe 2 or 3 questions on treatment. So in the majority of cases, you explained to us, it would be fundamental to identify the underlying mechanisms and to treat these underlying mechanisms. Are there some patients who are so severely impaired by alkalosis that we do not really have the time to wait for the responses to these treatments, and that we should give some kind of acid treatment directly?
Yeah. So the things that we mentioned in the paper that may fit in that regard, one relatively common scenario, of course, would be somebody with total body salt overload, let's say a bad heart failure patient with reduced ejection fraction, somebody in whom had been treated with vigorous loop diuretic therapy. They now have a hypokalemic alkalosis. Now, traditionally, that would be a chloride responsive disorder, but in somebody with severe heart failure and reduced ejection fraction, it's not feasible to give them additional salt. Moreover, you probably wouldn't be able to re-expand their effective volume because of the failing heart. So in that setting, oftentimes we then can capitalize on the utility of acetazolamide. Acetazolamide will inhibit proximal bicarbonate reabsorption. And in fact, the effectiveness of acetazolamide is greatest with the highest bicarbonate concentrations. As bicarbonate concentration falls, acetazolamide's effectiveness starts to wane. So that would be one example. Rarely, you have to consider the use of intravenous hydrochloric acid. Now, we didn't really get into that all that much in the paper other than mentioning it, but potential scenarios where that might have a role would be, again, somebody with bad heart failure and alkalemia who is now experiencing toxicity, that is angina from coronary vasoconstriction induced by the alkalemia, maybe even cerebral manifestations from the cerebral vasoconstriction. Again, it would not be a common scenario, but there definitely are occasional patients where one may actually have to consider using hydrochloric acid through a central catheter. And there are references, we provide some references in the paper about how one might utilize that as a therapy.
My last question on treatment. So if we have a patient with primary aldo that is driving the alkalosis, and if we want to treat this patient by mineraloreceptor antagonists, should we start with low dosages as we do in hypertension, or do these people really require higher dosages such as, say, 25 or 50 milligrams of spironolactone? So how would you recommend us to start in these patients?
Yeah, I think one has to individualize it, but my experience, and I don't see a lot of these people, but I do see some. In general, they do require a higher dose than what we've typically utilized. So, in drug-resistant hypertension, you might get by with 25 milligrams of spironolactone. But once you start to get people who have adrenal adenomas or even bilateral hyperplasia, the patients that I'm thinking about that I've been involved with have required doses, 50, 75 milligrams and on up. So yeah, I do think that those patients in general will require a higher dose. That would be my comments there. Yeah.
So thanks so much. You convinced us, and I guess all of our followers, that nephrology is really the king discipline of internal medicine, because it becomes difficult when it goes to electrolytes, and it becomes even more difficult when it comes to alkalosis, I guess. And now
Absolutely.
we invited you as a small Christmas present, actually, to our audience, since we discussed half a year ago that you are arguably the only nephrologist who did the 7 summits, and you have such a great experience in mountaineering. You talked a little bit about these summits in springtime, and now we are close to Christmas, and you have some video for us as a free Christmas present.
Yes, I do. And so I hope the audience will bear with me. It's a very short video, but it shows you some mountains that are here in the El Paso area. And if you ever have a chance to come to El Paso, I think you'd enjoy it. Our climate here, it's all desert. And so these mountains are the tail end of the Rockies. And so from the top of the unique feature about these mountains, when you get towards the top, you can see 2 countries and 3 states. From El Paso, because we're right on the border, you can look into Mexico and in the United States. And the 3 states are the state of Texas, the state of New Mexico, and the state of Chihuahua, which is in Mexico. So we see 3 states and 2 countries. So keep that in mind as I share this very brief video with you. And it also shows my wife, Dr. Deborah Clegg, who is my co-author on the paper.
Another climb of Mount Franklin, but a very steep route right through there. There's Debbie, and there's the Elephant Rock. So we got a little ways to go still. Okay, we're here at the base of the elephant. They call it the elephant because from a distance it looks like an elephant. Pretty steep right in here. So we're gonna be going over to that side. Debbie's taking the direct route up the elephant's main facade. Not many people climb this way. This is very steep, my friends. Good job, my friend. Good job.
By the way, if anybody has any interest, I always make little videos of our climbs, and I usually put some good rock music in. So here's the website for the Biff F. Palmer channel. Take a look at it if you have any free time.
And I guess unlike the Zugspitze, you usually do not have any snow there in December on your mountains, do you?
No, it's strictly a desert. During the summer, you have to be aware of the rattlesnakes when you climb.
Do you? Thanks so much for both this academic part and surely also this idea of the Texas mountains. It's a pleasure to host you. And we wish you Merry Christmas and a great 2025. Thank you.
Thank you very much, and the same to you. Thank you again.